Thank you, Ivory, and good afternoon, everyone. Ivory, thank you for that introduction and making us always ever so mindful of the land on which we live. I'm with the Federal Reserve Bank of New York, and we're located on Manhattan, of course, and this is the ancestral lands of the Munsee Lenape. Today, we are going to continue our conversation of the last few days. We had a wonderful serving of information and how folks look at evaluating programs associated with a culture of health. Today, we're essentially the dessert. We're going to talk to some folks who have helped us, who will help us understand how they look at evaluating their programs, their various activities in pursuing a culture of health. My name is Otho Kerr. I'm a director with the Federal Reserve Bank of New York. I'm the director of strategic partnerships and impact investing. I'm also an advisor on the Culture of Health program here at the National Academy of Medicine. For the last 13 years, I've actually been focused on impact investing. I'd like to think I've been one of the folks who've helped to create the impact investing sector. And in that environment, we spend time trying to understand, how do we measure impact? How do we understand the work that we do? And there's so many different ways of looking at how we measure impact. One reason for measuring impact is not only for the end goal, not only understanding the final objective, but it's to see how you're doing along the way. Measurement along the way makes sure that you're staying the course. And so we think it's important to measure, but there are all sorts of ways to measure as well. Do we look at measuring breadth or depth? And what I mean by that is we can spend time on interventions that have incredible impact on one or two individuals or a small group of individuals and have outstanding impact. And so you have depth of impact, but we're not covering a wide swath of individuals. You can also have interventions that cover a wide swath of individuals, but not necessarily with the same depth of impact. So breadth and depth are important. We also look at individual outcomes versus systems outcomes. We weigh that tension. What are we trying to do? What are we trying to achieve? And systems outcome is certainly something that we heard a lot about yesterday. And so one of the things we'll want to hear from our panelists today is how they look at the programs they are working in, how they look at impact, what drives them, where does the community voice play a role? Where does a shifting of power play a role? Who gets to decide what is measured, what's important? We are going to invite you all to participate by asking questions of the panelists along the way, but I will certainly have the joy of asking some questions and probing a little bit myself after the panelists have made their presentations. And right now, it is my wonderful honor to introduce the panelists. Our first panelist is going to be and presenter Donna Galbreath, who is the Senior Medical Director of Quality Assurance for Southcentral's Foundation's Medical Services Division. She provides direction and strategic planning and development of SCF's comprehensive quality assurance program to achieve optimal healthcare delivery. Under Donna's guidance, the organization achieved the Level 3 NCQA, Patient-Centered Medical Home Status for high-quality healthcare improvement. Her leadership was essential in helping SCF receive the Malcolm Baldrige National Quality Award for Performance and Excellence in 2011. She presents nationally and internationally in quality assurance, corporate compliance, and FCF's relationship-based NUCA system of care. Our second presenter panelist is Gloria Dickerson, who is the CEO and founder of We Together Creating Change, a social change community-based organization headquartered in the Mississippi Delta in Drew, Mississippi. In 2009, Ms. Dickerson retired from her work as financial management professional and a program director in philanthropy and returned to her home with a mission to be a change agent to transform low-income, socially disadvantaged communities from perceived places of poverty, low skills, and despair to communities of prosperity, abundant skills, and hope. Her focus is on holistic solutions in which the communities learn how to create a path to unlimited possibilities in spite of socioeconomic circumstances. Our third panelist and speaker presenter is Mary Bogle, who is a principal research associate in the Metropolitan Housing and Communities Policy Center at the Urban Institute. Her research often sits at the intersection of whole family support, social networks, and economic development at the neighborhood level. Over the course of her career, Mary has worked extensively with and for community-based organizations, government agencies, and foundations to plan, implement, and evaluate programs and policies aimed at creating more prosperous futures for children and families with low incomes. And last, but certainly not least, is Abby Goodwin. Abigail leads Palm Health Foundation's grant-making strategies and priorities, supports the organization's learning culture, and works closely with the board and the president CEO to fulfill the foundation's vision and strategic purpose. She leads the foundation's place-based grant-making initiative called Healthier Together by supporting the county-wide community-led process to impact health equity and enhance communities' power to influence the change they want to see for themselves, a theme that we'll see throughout the afternoon. She represents the foundation in several system-oriented change efforts. In 2018, Abby was named the Terrence Keenan Institute for Emerging Leaders in Health Philanthropy Fellow at Grantmakers and Health Distinction. So, without any further delay, I'd like to bring on Donna Galbreath, our first presenter.
Oops. Hello, everybody. There, my video is working now. It wasn't working for a minute there. For some reason, I'm going to share my screen with you, and hopefully that's all coming through. There it is. Okay. Well, as you heard, I work in Anchorage, Alaska. I am on the land of the Donna people. I work at Southcentral Foundation, and this is part of the Alaska Native Medical Center. So a big part of what we do is recognizing that everybody has a story behind their eyes. Everybody has a past, everybody has their own culture, everybody has their own beliefs and their own history. And this impacts who they are and how they interact with people. Along those same lines, I'll tell you a little bit more about me. I am Otna Athabaskan. I am from the village of Mentasta Lake. That's in the interior of Alaska. And I have worked with Alaska Native people as a family practice doctor for many years, and I am a medical director now. So you know a little bit about me, and every time you meet a person, there's a little bit that you can learn about them. And it's really important in healthcare that you connect with people and you know where they're coming from, you know some of their history, so that you can actually be able to have those deep conversations that are necessary to help people understand and make changes. So we're a Native owned and operated organization. We try to have a large number of our employees Alaska Native or American Indian. Right now, we have 52% of our employees that are American Indian or Alaska Native. We try to support all of our employees. We want everybody to be successful. We have lots of education built into our programs. We also have different types of support for employees, such as we have a program for CMAs in training and RNs in training. For admin support, we'll hire people straight out of high school and train them how to be an admin support. And we expect all of our employees to advance if they want to, if they choose to. And we put those mechanisms in place. If somebody wants to get a degree, we do have some scholarships available, and we even give some time off to be able to take a class and eventually get a degree. So we have built-in equity to our program just because we're Alaska Native owned. And we constantly talk to the people we serve. And also, you know, it's nice having 52% of our employees being Alaska Native or American Indian because they also have a lot of say in what we're doing. So our vision, mission, our goals, our leadership principles, and our operating principles are all based on what the people we serve have told us they want to have. and it's built on the beliefs of our people and the cultural values of our people. It's just actually, it's built into everything we do, to the work we do. Before we do anything, we make certain that it aligns with our operating principles. We also know words are important, so we rarely use the word patients. We use the word customer owner because we believe that American Indian and Alaska Native people have paid for their health care and they own their own health care. They paid for it with land and resources. We also believe that people should be treated as customers. They should have certain expectations when they walk in, even though we're a healthcare center. We want to make certain that they feel like customers and that they can come in and ask for certain things, and we want to make certain that they know they own this healthcare system. Since we changed everything within our system, we want to make certain that we're in alignment throughout the whole organization. So we have something called core concepts, where every single employee is trained about our values and our beliefs, and about telling story, about sharing story, and gives us common language for the work we do. We look at data all the time. This is our scoreboard scorecard right here. This is the most current one. We just came out with this one for this year. Blue is excellent, and then of course there's the green and red that tells us different areas that we need to work on, or sometimes we will put in an area that we feel like we need to work on, like the postpartum depression. That's a new one for us, and so we're working on that. So we know it's going to be red, but it's just to measure it through time as we move forward. So we're constantly looking at our data. We have a ton of data, and part of it's because we changed how we deliver health care. We changed so many things that we wanted to make certain that the changes we did were positive changes. And so we have had data for a long time. Our data is really important to us. It updates on a regular basis. A lot of this data here, well, actually, some of this isn't clinical, but if you look at the up here where you have the teams, the one east, one west, those are medical teams right there. And you can see, you get the scores of the individual teams there. You can also get overall scores. And then, and if you look down, like on the 3 west, that one's opened up and you can see names. Those are actual providers who work within our organization, and you can see their individual scores. We don't blind this data. Any one of our employees can open this up. Our employees can open this up and take a look at the data. They can see how they're doing. If you look down at the middle Pareto chart, you'll see that there's names down at the bottom. Those are all providers, and you can see their individual scores and how they compare to one another. We can use this Pareto chart in many different ways, but one of the things we can do is look at those people who have scored really high, and if they are consistently very high, then maybe they're doing something that we want to roll out to the rest of the organization. On the other hand, somebody who scores low, we usually don't have to say anything because our providers are actually very competitive, and nobody wants to be on the bottom there, so they usually get off of there pretty quick. So it just a lot of mechanisms that we use for data. One of the other things that we do is we make certain that data is user friendly. So I think I said it's updated every day, but our providers, so if they're looking at, let's see, what do we have on there? We have the eye exam for diabetes, I think it is. If you're looking at that and your scores aren't where you want them to be, you can drill down into your individual scores and actually see all the customer owners who are due for eye exams. And then you can also look at everything they're due for, because that's how the system's set up, and you can get them scheduled for everything that they're due for. And it just really helps manage your panel. So we've made it very user-friendly. It's easy to use. Providers know how to use it, and they use it to the benefit because it actually helps our customer owners. So we have had sustained improvement through time. Our employees are happy, our customers are happy. We've also shown that we've had decreased emergency room visits and decreased hospital admissions through time. We constantly are surveying our customer owner, but every once in a while we'll do a needs assessment. This is a much more in-depth assessment. to find out, where we're at and what we're doing, what our customer owners are wanting, what our employees are wanting, and opportunities for improvement. So these are usually the things we look at. We want to know what people, think are the greatest healthcare needs, not just our customer owners, but our employees, and a lot of our employees are our customer owners. And then just what they think of the organization. Are they able to come in and access our services? Do they feel that their culture is being respected, and what do they think of the qualities, relationship, and the alignment of the goals that we have within the organization. So we did this last in 2017, 2018, and we actually compared this to 1993, and you can see, we have improved because we're in the orange there, and you can see where we started way back in 93, and we continue to look at this and continue to see where we can improve through time, where our opportunities are. We also look at, our employees. So this is the engagement indicators for our employees. So, do they like working here? Do they plan on staying here for 3 years? Would they recommend this organization to somebody else? And we score very high on that too. So voice is extremely important. We're always talking to our customer owners, and it's not just, the survey that I was talking about, and that's not the regular surveys that people do, every year to every 6 months. We actually do, we want to know what our customer owners want. And so after every visit, we offer them the opportunity to give us feedback, and we make it easier. We use a little questionnaire that they can actually, just click onto it and answer about 6 questions on how their visit went, whether they were involved in their own decision making, whether their culture was respected, and questions like that to make certain that everything we're doing is important. So the voice of the customer owner is extremely important because we want to know that we're meeting the needs of the people we serve. It's also important, as I mentioned, to know what our employees think. Are they happy? Because if the employees are happy and they believe in the system of care, then it actually improves the overall quality of care. So we're constantly measuring things. Data is important. The clinical care is important. We compare ourselves clinically with HEDIS measures. We're typically in the 75th percentile for HEDIS measures. So we're always constantly looking at data from every aspect we can think of around what our customer owners have told us is important for us. Thank you.
Thank you, Donna. I'm not very effective at going off and on mute. Thank you, Donna. We will come back to you after we hear from the others. The next presenter is, I lost track, is Gloria, Gloria Dickerson, who's the CEO and founder of We Together Creating Change. Thanks, Gloria.
I'm unmuted and I'm trying to start my video and it won't. Okay, here we go. Here I am. Okay, like he said, Otho said, I'm Gloria Dickerson, and I'm going to talk about evaluating the impact of community and civic engagement in building hope for health equity in the Drew community. Let me tell you something about next. Can you do next, please? Tell you something about Drew, Mississippi. Got to describe what it is. It's a rural community in the Mississippi Delta. It was a prosperous community in the 60s and the 70s for the farmers and the plantation owners, because there's a lot of farming here, but not for the sharecroppers. And so most of the people who lived in Drew back in the 60s and 70s were sharecroppers. They were deeply affected by racism and segregation. I guess I should say we were deeply affected by racism and segregation because I lived in this community as well back in the 60s and 70s. Actually, I was born here and grew up here. And white flight in the early 70s with the integration of the public schools. Okay, can you go to the next one? That's Drew, Mississippi. Now, Drew today, the population is about 2,000 people who live here. 79% are African Americans, so most of us are African American, and 19% white, 14% other races. The child poverty rate here in Drew is close to 30%, and 51% of the people earn less than $25,000 per year. And the infrastructure is also deteriorating. Now, the key things that really contributed to examples of infrastructure deteriorating, the Drew High School closed, so the kids had to be bused to another town. The public schools are 98% Black now. The last grocery store closed here, so we do not have a grocery store in the community. And there's also difficulty attracting private, state, or federal investment. So disinvestment in the community. Okay, next. This is just a scene of what Drew looks like now. Next, you can go to the next one. Now, what happened was I came back to Drew in about 2010 or 11. And because it was my hometown, I didn't like what I saw, and I thought we could do something different. So I came back to Drew to help. And what we did, we did some listening visits. And when I got back to Drew, I started teaching at Drew High School. In Drew High School, and I was teaching African American history. That really opened my eyes to what was going on in the community. And I also had some listening group with the youth at the school and learned about what are your concerns about your school? What are your concerns about your town? What would you like to see in your town? We also did listening visits in the community and built some relationship with the community leaders, such as the mayor and the board of aldermen. Did all that, just listening, trying to find out what's going on here. And then this Drew United for Progress was formed. This is an organization that came to we together and say, we really do want your help since you're back. And so we got together and started talking about what we wanted to do and decided that we needed to do a strategic plan because we want to listen to the community. When I say we, I mean the organization. We want to listen to the community about what it is that you really want in this community. What can we create? And we talked about things such as recreation, the grocery store not here. No one had access to fresh foods at all. Couldn't buy apple or banana or anything like that in the town. We talked about how we wanted downtown to be renewed. The housing, people want housing. They won't be able to get to health care. With no transportation, it was difficult to even get to a clinic or get to anywhere to get some health care. They were also concerned about the community environment and the appearance of the community because there were a lot of blighted homes in the community that really looked not very good appearance. Infrastructure, the roads and the streets were in bad shape. And they said they wanted some community learning and some vocational training. All this came from the people because when we together first came back, we were focusing on the kids. Drew United started because the adults said, we want to be involved with whatever you're doing with our children, and we want to get involved in improving our community. It was their idea. These are the things that the community decided they wanted to do. So our mission, even before I came back, to transform an impoverished community to a thriving, healthy, happy, and prosperous community for all of the residents that live here, including everybody. Okay. All right, you can go to the next meeting. Now, so why is community engagement important? That's what we asked ourselves. Why is it to involve the community? These are the things that the community have voiced their concerns about and voiced that they want to see in their community. So why is that important? Well, community members are experts on what they want in their community. People who live outside the community do not actually know what people want in their community. So we will go to the community members. The community members take ownership of the community when they are involved. So they were involved. So we decided we needed to involve them. Community members have solutions. They tell you what they want and they tell you some of how we can get there. And when I say community have solutions, if they don't really have it right there in front of them, they have some ideas of where they can get these solutions. And involving the community to transform the community builds pride and also builds hope. And what I found when I went to listen to the people in the community and listen to the kids and listen to the students, a lot of them didn't have a lot of pride and they didn't have a lot of hope. Okay, next, please. So we decided on community engagement because we wanted to fulfill the strategic plan. That was all put into the strategic plan. All the things that they said that they wanted, we put it into a strategic plan. And then we went about trying to decide how we were going to get there. And so we've had some successes, which I'll talk about later, but to measure whether the community is really engaged or not, we do, and whether it's a change in behavior or a change in how individuals think or whatever about possibilities. And so we measure number like that, who's attending the community learning classes and how many are on the wait list to attend. We have learning classes in the community, and we have a lot of people on the wait list because we can't accommodate all of them that want to come at the same time. Who's participating in youth activities? And the youth activities are mostly to build hope in the kids, get them thinking more about their self-worth, life skills, and how many are on the wait list. Because we have programs, we have activities. We can't accommodate all the kids, so we have some on the wait list. So we always keep a tally or number. How many are here? How many people do we have on the wait list who want to get into this class? And is it declining or not decreasing? How many people are attending the community meeting, whether it's increasing or decreasing, because we want to keep the people engaged and involved. So how many is going down? The same thing about the community service projects, community members who are leading the teams. We have community members who lead teams, some want to head subcommittees, and is that increasing? Voter registration drives. How many people are going to city meetings, city hall meetings, and the school board meetings? How many people, once we got our recreational spaces, how many people are really utilizing that? How many adults are utilizing the recreational spaces? How many children are utilizing those recreational spaces for physical activity? We also we're training them on the use technology. Training goes on use technology because we do have a program now where they can access fresh food and healthy fresh food through technology. And so I can talk about that in a minute. How many people are using the technology now? And we also now have a mobile clinic. How many people are actually coming to the healthcare, the mobile clinic? We brought one in, and we want to know, are the people using it? Okay, next. Now, these are some slides where we just let's take a picture of how the people are engaged. They're engaged in helping clean up. They're engaged in coming to class. They're engaged in coming to meetings. And so that's just some pictures of that. Can you go next? Next. Now, in addition to the numbers of how many are doing this and how many is this and how many of that, we also want to know the thinking needs to come from the community, not from just an organization. So we have written testimonies from community residents where they tell us, we ask them questions like, what are you thinking now? What are you feeling now? How do you feel now? How have any of the improvements and trainings impacted your life? How has it impacted your children's lives? What is needed to impact your life in a healthy way? We ask them those questions. And that's where once we ask these questions, we use this feedback. We use the feedback to do some intervention. For example, your stress levels, we started doing meditation and that kind of stuff, and mindfulness, and Emmett Till Academy, where we teach the kids about well-being and that kind of stuff. Next, please. And then what do you see? You know, a lot of people say when people come into our community, nothing changes. So we ask them, what have you seen that has changed in your community? What about the physical environment? Do you see your housing and other things? What do you see that you thought we would see based on our plan? Next. And so these are some of the things that we have done. The mobile clinic, dilapidated housing, putting a roof on the library. Next. And the last slide is we disseminate that back to the community. I mean, we go through social media, newsletter, newspaper, community meetings, all of that, and give a report to the community in terms of what have we done. And we ask them to not only tell us the physical things they see, but other things that have happened in their lives. For example, someone said, I have manifested the things I have learned in this class into my life. Someone said, we learn what it means to have social justice and equity in our lives. So those are the kinds of things that we use in order to get feedback, in order to go back and update our strategic plan and look at that strategic plan and say, okay, we've done this, we've done that, and we keep working on the strategic plan until we get all of those things done. We are going to keep working. I think that is it. Next. That's it. All right, bye. Okay.
Thank you, Gloria. We will come back to you with some questions. Fascinating. I have some follow-up questions just to see where you all are today and what solutions the community has come up with. So I'm really eager to come back to you. Mary, it's nice to see you. Mary, as I introduced earlier, is a Principal Research Associate in the Metropolitan Housing and Communities Policy Center at the Urban Institute. Welcome, Mary. It's nice to see you.
Thank you. It's good to see you too. All right. I am just set my timer for my timing, and I'm going to share my screen. Technology is always a little dicey for me. Luckily, I have people on my teams who know how to do things better than I do. Here we go. And from beginning. All right. I think that my slides are up. I am the principal investigator. As Otho said, I am a principal research associate at Urban Institute. I do a lot of work nationally. The things I study are well-being, household well-being. I have a background in early childhood. A lot of what I'm focusing on at the household level is cash transfer and guaranteed income at this point. But I also do a lot on social networks and equitable economic development. And I try to bring those things together intersectionally in my work because I believe those three things are really very formative to mobility from poverty and into, economic prosperity. I am the principal investigator for Thrive, the evaluation of Thrive East of the River. I do a lot of my research in the greater DC area and in the District of Columbia itself. And Thrive is an evaluation that came my way at the start of the pandemic when 4 community-based organizations in Ward 8 of the District of Columbia came together to respond to the economic lockdown that was facing the families they served in Ward 8 of the District of Columbia. And their goals were to address the immediate danger posed by COVID-19 to this group of historically marginalized families. And they were they had been doing good work with the families. Some of you may know these organizations. They have great reputations in DC and it certainly, and even nationally. One was Bread for the City, one was Martha's Table, one is Building Bridges Across the River, the 11th Street Bridge Park, and one is the Far Southeast Family Strengthening Collaborative. And they all work directly with families at different levels. They have different missions. Martha's Table is focused on early childhood and in food services distribution. 11th Street Bridge Park, which I'm also the principal investigator for their 11th Street Bridge Park evaluation of their equitable development plan, they focus on more community development level things. The other 2 organizations, Bread for the City and Far Southeast, do a lot of services navigation. Bread does a great deal of equity work and also is very involved. I would say Bread is one of the organizations in the District of Columbia that deals with the most deeply poor folks, the lowest income, sort of below 50% of the poverty line is pretty typical of their clientele. So anyway, they were looking at a real crisis at the beginning of the pandemic for the folks they served, who they felt that their services were stabilizing, in some cases lifting out of poverty. And here comes a pandemic. And just to give you a sense of Ward 8, Ward 8 is a historically disinvested community in the District of Columbia. There's a history. Our report is about to come out. We're going to spend a lot of time on the history because it's important for folks to understand exactly what happened to this community. To lead to conditions in which 34% of the residents live below the poverty line of the households. 90% of the Ward 8 community is Black, and they experience a 19% unemployment rate in Ward 8. 56% of the residents of Ward 8 are housing cost burden, and 44% were working in COVID, of the employed folks were working in COVID impacted industries like hospitality and things like that. So they came together to do these goals. It's alleviate crisis, stabilize families, foster mobility. Finally, what the partnership worked towards to do these goals was they delivered $5,500 payments in one payment or monthly payments. They delivered weekly groceries and dry goods and assistance securing other resources to 400 to 500 households in Ward 8 who were below 50% of AMI, average median income, lived in Ward 8, and were among their clientele. Those were the criteria. One of the key things about Thrive was they established a set of core values up front. And this, again, they believed in the value of the power of the residents to make their own decisions, treating everyone with respect, integrity, and they believe in racial and economic equity. The evaluator, as an evaluation partner, we were also bound by these, and I'll get into a little bit how these values affected the evaluation agency. The Thrive evaluation. Urban was brought in as the external evaluator. Our research questions centered on outcomes vis-a-vis the 3 Thrive goals. We provided a continuous feedback loop function too. We provided data back and data reports on a monthly basis. We also sat in weekly on the operations. We call it the ops and eval, the operations and eval meetings, so that we could continue to provide rapid feedback, dig up research on things. There were some complicated issues Thrive ran into in terms of concern about benefits reduction. If you give people 50,000, or sorry, I wish it was 50,000, 5,500, does that affect their benefits? And what are the benefit cliff issues that could be experienced? What we did was 3 surveys via our Qualtrics system. Obviously, pandemic conditions made a lot of face-to-face things harder. One of the methods we used is comparing that data to the Census Pulse survey. I'll get into a little bit about that later. We did interviews with staff participants and stakeholders, and we used a lot of program data, enrollment data, service navigation, things on service navigation, and their financial coaching data. This is all in our final report, which will come out in mid-February. We also used community researchers, and that's one of the things I wanted to focus on today, was that we hired and trained 5 community-based researchers from Ward 8 to assist with qualitative data collection and analysis. They received ongoing on-the-job training and were paired with staff researchers for interviews. So we actually partnered with Far Southeast Family Strengthening Collaborative to do a lot of the onboarding and recruiting, did the joint training with that particular CBO that was well positioned to do it with us. And then we took the 5, there was actually a pool of 10, but we ended up with 5 folks we hired. The other 5 either declined after training to continue to participate, or are waiting in the wings, and Urban is looking at ways to use them in future evaluations, as we are with the other 5 that we trained. A lot of what we had to focus on in training, besides the usual of describing things, talking about what they would be doing, we did a lot of role modeling of how you conduct a qualitative interview and how the staff researcher and the community-based researcher would trade off roles. We spent a lot of time on consenting and confidentiality procedures and IRB type training because these were people in Ward 8, and we needed to do a lot to make sure that they didn't know any of the participants. They were not participants in Thrive itself. They were recruited in other ways. We're looking, this has been so successful, and we were so pleased with the results of this, that Urban is now working on a career ladder for community-based researchers. I'm on the work group for that. Our lead community-based researcher, Hope Fultz, from the study, is now on 2 additional studies with me doing interviews. One involves foundations and how they're funding in Ward 7 and 8. Another involves a very new, just announced yesterday, Advancing Cities Initiative grant in Ward 8 to Martha's Table. So we are going farther with this element. So I wanted to pause on that, because that was one of the ways that we took the evaluation, the Thrive values, and its focus on equity, and we said, how could we make it so that that the community itself, that we had that lived experience, not just that we were asking people, but they were embedded in the evaluation team. We felt very good about the results, and we still do. And just to give you a sense of the Thrive outcomes, one of the things we measured was how did folks spend, and you guys are getting the preview because we have not published our report yet, but this is actually some of the data in the report. What we saw was that people spent a lot on housing and food, but also transportation, internet, and phone. But housing and food were definitely the top 2 spending categories. So we know that also in terms of outcomes, the program had a substantially positive impact on food security for households and mental health for adult participants. We saw some qualitative and sort of very modest gains in child well-being. We think had we been able to follow the families longer than the 1-year duration of the study, we'd probably see a larger child well-being impacts, but there was a lot going on for children, as we all know, during the pandemic. So we think the fact that a lot of the qualitative data about parents saying that they did things for their children, they felt so much relief. And we think the adult mental health impact, sort of its social determinants look of receiving the cash and the trust and respect that went with the cash may have had some very positive impacts in households, just based on some glimmers of data. Again, unfortunately, the horizon of the study is not such that we were able to see the child well-being as much. But as I said, the effects on food security, this is one, and mental health were quite extraordinary. This is compared to pulse groups. You can see that the Thrive group, I have to close this little side window I have here. As compared, Thrive, 19% of Thrive participants throughout, at the time that we surveyed them, said they still had insufficient food. This is compared, though, to 30% and 34% of low-income people nationally. So you can see Thrive participants are doing much better, and it well exceeds other low-income and Black folk around the DC area. So that we consider the food security results. We see similar things in adult mental health. One of the things that I will hold up that I think that having the community-based researchers did for us was that it gave us a lot of lived experience insights from the community-based researchers. We brought them into the analysis as well, had meetings with them to say, okay, what are we hearing in these interviews? Here's what we're seeing in quantitative data from our surveys and other sources. What do you guys think? And I will admit the staff researchers, including me, were mystified that there was so much spending on food when in fact there was the food delivery service. And and I think that some of the implicit biases, and I'll be transparent about this and admit that right away I was like, well, why wouldn't people use the food? But the community-based researchers were really the ones who said, look, it's the middle of a pandemic. People didn't want to go out. And then we got into a discussion about food choices and Thrive values and how often what comes in food boxes, and these were still wonderful food boxes, they were from Martha's Table, but that a lot of times it did not meet the family's preferences. And that was important to folks, especially in the middle of the stress of the pandemic. And it was likely that people really preferenced using their cash on grocery services because the utilization rates for the food service really did fall off over the course. And we have a whole discussion of this in our final report. And we use some national research data about what happened in terms of food banks during the pandemic, which experienced sort of a similar issues that we talk about and we use as context for understanding a finding that would show that participants spend a great deal of their money, the cash on food, while at the same time having a lower utilization rate of the food service. Again, some of our findings in this study make me wonder, was the intervention really delivering cash, or was cash just a vehicle for the trust, choice, and equity that the values were intended to deliver and to provide to participants? And I think that's, really very important. I could talk to you during Q&A. I'm running out of time in this presentation, but about what we found about systems barriers and how they affected some of those choices, some of that choice that Thrive intended to deliver. A great deal of our findings show that they did. The fact that there was a moratoria on A lot of asset limits and eligibility limits during the pandemic helped with the choice element, because we really didn't have to worry as much about benefits cliff as you would normally. But we did see that the fear of the benefits cliff that the families live with did impact some of their choices, especially in how they chose to receive the money and how fast they chose to spend it. So I'll end there. Again, I can get into more on the systems barriers during Q&A. I can even talk to you a little bit about whether or not the Thrive evaluation was anti-racist. I was asked to present on that to an internal group at Urban, and I think there's some interesting, the answer is yes and no. And that might be helpful to folks in terms of research-based standards. So there goes my timer. That's it for me. Thank you.
You can bet we're going to come back to you with those questions on systems barriers and whether or not the Thrive survey was anti-racist. Thank you so much, Mary. And our last presenter and panelist before we go into a little Q&A will be Abby Goodwin, who leads Palm Health Foundation's grant-making strategies and priorities.
Hi, everyone. I think I have all my parts in place. Wow, what a panel to be a part of. I am just really appreciative of the comments so far and the diversity and range of experience. So I'll just build on that diversity. Palm Health Foundation, let's see if I can advance this. There we go. So Palm Health Foundation is a health conversion foundation serving Palm Beach County, Florida. And we're known for our convening and collaborative nature and our forward-thinking approach to addressing health here in our area. So on behalf of the Culture of Health Prize-winning community, Palm Beach County, I'll provide a very small window into many of the things that are taking place here around assessing our progress against improving health for all. Specifically, I'll talk about our process of supporting resident-led efforts through complexity science and how we're designing, monitoring, and assessing progress within our area's budding health equity network. First, a few notable characteristics of our area. So you can see on the map there, we're considered part of South Florida, along with Miami-Dade and Broward counties. And we have some of the demographics here, including some of the disaggregated data that our team pulled out from the Child Opportunity Index. And I'm speaking to you from the ancestral lands of the Seminole people in West Palm Beach. So our learning about evaluating health equity has been steep and continues to be so. In recent years, we have given more attention to how we measure than what we measure. The how we measure, the how conversation really has centered around being equitable in the learning process, to pay attention to power dynamics, and to challenge our typical evaluative approaches, which oftentimes can feel more extractive than truly supporting those who are most proximate to the challenges our communities are facing. So we ask many questions, like many of you do. How are we using the data that we're actually collecting, and who does it really matter to? And we have really centered our work and approach in this area with this phrase: anything you do for me, without me, you do to me. So we're still learning, and my comments today are a point in time in our learning journey. In 2018, when the Water Systems Change was published, it really helped anchor some of the things that we were already experiencing here in Palm Beach County. And you can see in the top tier, policies, practices, and resource flows really lend themselves to more traditional evaluative measures. But we were really seeing in our experience that the second and third tiers were incredibly important to community change work. really centering the power dynamics, the relationships and mindset. And that's where we've been spending the last 5 to 7 years wrestling with and these harder to reach spaces. So Palm Health Foundation launched the Healthier Together initiative, which is a highly localized health equity network in 6 communities. We invested in each community, and the initiative is community-led, where residents design their solutions, name their problems, the challenges that they're seeing, alongside organizations and systems. And they're also very much deeply embedded in the learning, accountability, and communications process. And that is how we unpack what we mean by assessment, is learning, accountability, and communication. As a foundation, we set out with this initiative to reduce diabetes rates, increase mental health access and stigma, and address family caregiving. But when the communities defined their challenge and solutions, our impact goals were no longer relevant, and we had to rethink our entire approach to assess our $6 million investment strategy. Instead of adopting a goal of reducing diabetes rates by 2.5% in 5 years, Healthier Jupiter moved to build conditions for healthy eating and active living. And instead of tackling the stigma of mental health and accessible services, Healthier Glades set out to rewrite their community's narrative from one of poverty, despair, and hopelessness to strengths, assets, and treasures. What began as a very traditional goal-oriented systems thinking change initiative quickly pivoted to honor the residents' perspectives, and it really tested the foundation's authenticity in this process. So instead of embarking on formal goal-setting process for each of the community-led efforts, the communities adopted a change we want to see lens, language here being central. And as a result, we began to privilege emergence, the generative ideas coming from the community to tackle their challenges. Through a series of highly participatory strategies where residents were trained and often led these discussions, ideas developed and were implemented. What we describe as safe to fail projects tend to be seeded with small amounts of money directed by the community. And these efforts are tracked, amplified if warranted, if the momentum's there, and dampened if the traction is not there. Sense-making has been a secret sauce in this entire process. Sense-making is a process where people come together to make collective meaning of the world around them, and then to take action, to take the next best steps. Sense-making can be extremely uncomfortable for folks who want to engineer solutions to solve difficult problems. Creating opportunities for folks to come together with no agenda and to reflect on their experiences, or maybe the data, or maybe to be responsive to those emergent ideas. Meaning the emergence in that space that's been created has been key, and it has signaled consistently to the community that this really is their space and their process. A tool we use to better understand the directional change communities want to see is the from to framing. And you can see here a few examples. For instance, through this work, our name used to be Palm Health Care Foundation. And a few years ago, we moved to Palm Health Foundation as a direct reflection of how the communities are defining health in the very broadest terms. Another tool that we use that aids us in this learning process is our wins. And wins signify milestones, turning points, directional movement, and even the setbacks to honor the learning that takes place from those experiences. And over time has really helped us spot patterns and signals about the impact and influence. So an insight win would be a key insight, like an aha moment that we all have. A capability win is when skills, knowledge, insight, or skills, knowledge, or resources are gained. And then an outcome win is when maybe lend themselves to more traditional evaluative measures. And we would also include policy wins in outcomes. So through this process, we have grown a lot of comfort with complex adaptive systems theory, which accounts for the highly dynamic nature of our world and our interactions within our world. And to operationalize complexity thinking, we have adopted the Cynefin framework, which you see here, a very simplified version for anyone who's familiar with it. So complexity science is teaching us that we tend to oversimplify the solutions to highly complex problems. We don't recognize the nature of the challenge, oftentimes, that we're trying to solve. We don't typically account for the context in which the problem resides, and the context can be more powerful than we give credit. And for our most challenging or complex challenges, we can't possibly know the cause and effect. And yet solutions we design often assume that the environment is stable and that cause and effect is present. So understanding the present can help us inform us where we stand and what tools to apply. So on this slide, you see 4 domains. The nature and characterizations of each of these domains are unique. And we're using this to map the work that's happening in these communities. So I will share an example. Very sensitive. Of the Healthier Lake Worth is one of the communities where they have connected the physical environment to behavioral health. So what they want, their connection is around community pride, trash, unsafe streets, unlit parks. So this was their first insight win, is connecting the physical environment to behavioral health. But what to do about it? It was clearly in the complex domain. And as an example of a probe or a safe to fail experiment, a gentleman stood up at a community meeting and said, you know, we've been meeting for some time. Clearly trash is the problem. Join me on Saturday morning and we'll organize a trash pickup. Well, that momentum really grew to multiple trash pickups over many, many months, several in a month. And the city started to take notice and began to resource this community organizing with supplies and even a special pickup to pick up the collected trash. Which then led to the first Adopt a Street program in the city, and is now there's a policy being worked on at the city in partnership with Healthier Lake Worth Beach for the frequent code violators on residential properties. The community group will be contacted and work with the city to leverage community and city resources to help these neighbors. And another benefit that has come out of this is community organizing around a segregation wall that has been highly controversial over decades. And within a year and a half, the community organizing, which grew from the street cleanups, focused their attention on the segregation wall. And now it is a beautiful, many, many murals of really documenting the history of the neighborhood and looking towards the future. So what started as a very complex problem began to have more predictable, stable boundaries around the solution. And as that certainty grew, so were the types of wins and outcomes that we were able to see. We are also using Sensemaker as a story collection software, and we're folding this into more settings. And this is from the mind of Dave Snowden and Cognitive Edge. So rather than stories being coded by and analyzed by qualitative researchers, the storytellers code their own stories within this platform and assign their own meaning, which on the back end produces quantitative data, which you can see in this triad. At points in time, folks gather to look at the data that's being generated through Sensemaker. And they're invited to really consider what do they want to see more of and what do they want to see less of. And this process is called Insights to Actions, and then develops a series of safe to fail experiments or probes to move the work forward. So instead of formal dissemination practices, we are prioritizing feedback loops and participation channels as action-oriented communication strategies or action learning. So feedback loops help maintain accountability by showing people what we thought we heard and have them reflect on it and be part of active parts of the learning process. And this is bidirectional. And participation channels offer opportunities to get more proximate to one another with people who they might not know otherwise, and are part of the co-designing process. Our communities are face the toughest challenges and these challenges are highly dynamic and interconnected. And like so many of our communities and neighborhoods across this country, people don't have the privilege of living and working and playing in stable environments. So creating space and resourcing communities to do what they know best isn't ordered. It's not clean. It's generative, and that can be a very, very messy process, but a deeply impactful one, and one that really challenges our systems approach. So while our inclination is to have ordered problem-solving techniques, we often track and manage these containers for change that complement the organizational and technocratic problem solving to better support them in these highly dynamic environments. So we really like this analogy. We tend to, if we're designing for a stable environment, that tends to be an organizational response and technocratic problem solving. While that's very important, we are also excited about this work really built around networks and highly relational that account for the more turbulent environment that certainly we have all been a part of as an example of the last couple of years. So we think a lot about setting conditions to address health equity, and we've really come to understand that everyone can exercise leadership, and this is a beautiful definition that we use from the Marshall Gowns community organizer. And our work, Palm Health Foundation has been part of some work with Rethink Health with the Ripple Foundation, and really have come to center stewardship, and where everyone, where we're all stewards of our shared resources. And this is, to me, a very ecological framing about interdependence. So if culture is about shared meaning, then we're building a shared meaning around what health means from the communities and taking direction. And if we're designing to be adaptive in our responses, then this health equity network is an amazing track for us. And I can talk more in the question and answers if anyone's interested in the more countywide impact from these highly localized pockets. And we have a mantra, is to trust the process. This process isn't linear and is often very uncomfortable for people who are working in more linear ways. But as we've heard today, and was a very strong theme yesterday in comments, is that trust is so important. And at the very, very foundation of trust is authenticity. And with that authenticity, relationships form and deepen. And that collective agency, this is coming from the California Endowment, that collective agency is developed. And as we share our belief in civic muscle and belonging, is at the very heart of this work. So this is a long-term work that we're very committed to. Our journey continues and our learning is steep, and we would welcome any additional thought partners as we navigate for the future. Thank you.